You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 341, and in this one I interviewed Dr Lynne Drummond. Lynne is an honorary consultant psychiatrist at South West London and St George's NHS Trust and visiting professor at the University of Hertfordshire. We discuss her therapy story, her new book, Everything You Need to Know About OCD, the stigma around OCD, raising awareness around OCD, a historical view of how OCD has been viewed, working with patients who have struggled with treatment in the past, how Lynne and her team were able to help these patients. We discuss medication, how Lynne explains exposure and response prevention therapy, optimising ERP, living with uncertainty, and so much more. And thank you to NoCD for supporting the podcast. NoCD offers affordable, effective, and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head over to go.treatmyocd.com/the-OCD stories, or the link will be in the episode description. So thank you to Lynne for her wisdom. I deeply appreciate it. And of course, thank you to you guys. As always, it means a lot. Without further ado, here is Lynne. Welcome to the show, Lynne.
And thank you, Stuart. Lovely to be here.
Yeah, it's good to have you on. So what I like to ask psychiatrists, psychologists, therapists is, what got them into doing this work, and then why OCD in particular?
Okay. Well, if we scroll right back into the mists of time, I was an undergraduate at medical school in Glasgow for 6 years. And of course, I started off wanting to be a surgeon, because everybody always does, although I was told repeatedly in those days that as a woman that was not an option, but that has never stopped me before or since. So, and then I went into psychiatry, and suddenly I felt this was my niche. I found it very, very exciting. At that point, there was less research. It was considered an underdog, but I thought it was exciting and different because it had so many opportunities. And I met my first mentor there, really, Professor Bond, who inspired me. And I went on from that. I did well in student exams, and I decided I wanted to be a psychiatrist. So I spoke to Professor Bond, and he said, well, there's 3 places you can go to: Oxford, the Maudsley, or Edinburgh. So as an undergraduate, I went round and talked to people in all of those places, and really decided I wanted at that point to go to the Maudsley. So in those days, they used to feel that to enter psychiatry at the age of 24, after you'd qualified and done your first house job, was inappropriate, and that you needed more life experience. So dear Dr Briscoe and Maudsley said, well, yes, we will consider you, but go away and get some life experience. And I said, well, what life experience should I get? And he said, go and do higher qualifications in general medicine. So I promptly went off, and that's normally a 3 to 4 year course, but I was so determined to get into psychiatry. I did it within 18 months and went back and said, please, will you now take me onto psychiatry training? And he hummed and hawed, and he told me I was still too young, but eventually he took me at 25. And my very first job, very fortunately, was with the wonderful Professor Isaac Marks. I wasn't directly working for him, I was working on his ward, but a lot of my friends to this day are some of the nurses from that ward. I know some of the doctors that worked then. And of course, Isaac Marks has been my guide and mentor for the rest of my life. And I realised that this was a really exciting area because we were taking people that were very ill, that this bear in mind is the very late 70s, early 80s, who were considered untreatable, and they were getting better. And I just found this amazing and met the most wonderful, we had the most wonderful patients in the ward who came from all walks of life, were really handicapped and got their lives back. And I thought, wow, this is what I want to do.
Amazing. And what led on to OCD?
Well, Professor Isaac Marks ran the OCD
of course,
unit.
Yes. Yeah.
So that was why, really. Yeah. And after that, of course, I went around and I did had various different experiences in psychiatry, but always had an interest in OCD and always used to try and slip back into Isaac Marks' research meetings and find out a little more. And so actually, when in 1985, a job came up at then St George's, now South West London and St George's, as a consultant. I was actually quite a bit too young, and there were many more senior people that wanted this job, because in those days, as a consultant, most people were around 40, and I was just 32. And I thought, oh, this is such a shame. This is my dream job. I really, really want it, but I'm not going to get it. But I will go for the interview. And I went to the interview. And then the third person that really helped me in my life, Professor Crisp, was interviewing from St George's. And I don't know what it was, but he saw something in me and gave me the chance. And I took that job in 85. And there I remained for 35 years. So,
and he was right.
Maybe he was. But I tried my best.
Yeah, of course you did. Yeah. And with Isaac Marks, when you started working with him, was he using ERP or systematic desensitization then? The ERP?
Oh, he was using ERP.
Okay, yeah. Okay.
He was using ERP, very much ERP. Yeah. I think actually much more severe ERP than we would use nowadays, actually. Yeah. It used to be a joke with all the patients and staff when we had the group meetings that everybody had their hands down the toilet that morning and things. Okay. But, hey, people got better.
Brilliant. That's awesome. Okay, so let's talk about your new book.
Okay.
Yeah, Everything You Need to Know About OCD is the title. So I guess just an open question, please tell us about the book.
Okay. Well, the idea behind this book was, as you gather, I've been in the area of OCD now for 40 years, basically. Actually, a bit longer, I suppose. And I felt that I'd learnt quite a bit over those 40 years. And I'd learnt that from my colleagues, but mostly from my patients. And I will say I do have patients, because I'm my GP's patient. I prefer that term, because to me it implies that I have a duty of care and a duty to do the best I can for that individual, which I don't think is ever conveyed by some of the other terms that can be used. But I learnt so much from them. And also I felt that very often when it comes to psychiatry in general, there can be egos getting in the way, and people have belief systems that they will carry through at the expense of all else. So I thought what I wanted to do was to write a book which just looked at the evidence as it was and presented everything about OCD. So in the book, in the first half of the book, I try and look at all the different proven treatments and thoughts about OCD. So I cover obviously psychological treatment, but I cover drug treatment. I even cover neurosurgery, and then new treatments and where we may be going for the future. But I hope in a way that is accessible to a wider audience. And I also do this because the way I learn with my patients is I give case history examples to illustrate what I'm trying to say. Then the second part of the book is about what you can do to help yourself with OCD. So it's like a self-help guide. And I've got chapters there that look on how you can help family members. I've got chapters on how to access help, and then the basics of an ERP program, and then the different themes of OCD and how you may tackle them. And again, I do that via case history material. Of course, not everybody is the same, and no two people with OCD are absolutely identical. But I feel that giving some ideas about people could help others in their struggle with OCD.
Yeah, really good. And I like the case history element. I think hence this podcast, but I think we learn historically as humans through stories, and a case history is a story.
Yes.
Yeah.
Absolutely. It's a life story of somebody. And sometimes I think when you're really wrapped up in OCD and you really feel there is no way forward, or you feel, actually, OCD may not be great, but what's life like out there? Actually hearing about people that have made that step, have made that jump, have taken the brave decision, can really be inspiring to you as well.
Yeah, absolutely. Spot on. Okay, so it's out now. Came out very recently. I will put a link in the show notes so anyone wants to go check it out and buy it. And of course, it's available globally pretty much in English at the minute.
It's in English. Yes, I think so. It's on Amazon. You can order it. I'm understanding. I don't know about the sales. That's not my area. I just produce the books. But my understanding is that if it's not out in the US, it shortly will be. But it's available through Cambridge University Press and through Amazon UK.
Yeah, I did actually check earlier. So in the US, it's out on Kindle at the minute.
Right.
And I don't think the print copies are there just yet, but it's available in Kindle. So cool. Anything else you think is worth adding on the book?
Not really. I think, what my motivation always has been in all of this is to say that, OCD, as we've already said, is a devastating condition.
Yeah.
But yet it's often not really given the importance that it deserves. And people with OCD are often very ashamed. They often hide away. So from that point of view, they're not out there shouting about it.
Yeah.
And they don't scare people. So therefore they're hidden and lives are lost. But despite that, we can do something about it. So what I've tried to do really throughout the last 40 years is to raise the profile, to get people aware of it. Because the more we are aware of it, the more information we have, the more we can demand that treatments are available. So what I hope with my book is, as well as being a self-help guide, by arming people with all this information, they can know what they're wanting and what they're needing, and to know that there is hope. So it's a matter of really trying to raise the profile as well.
Yeah, absolutely, and I'm sure it will do just that. Yeah. So on that kind of train of thought, then something else you've also been passionate about for many, many years is the kind of idea that OCD isn't a joke. And obviously in the media and the last 20 years, we've seen that, I'm a bit OCD or I'm so OCD, all these things said, or various TV shows just portraying OCD completely wrongly. Yes. Just anything you want to say on that?
Oh, I mean, it's very difficult. When I started out, as I said, in the late 70s, early 80s, actually, people didn't know what OCD was. If you said OCD, they'd look at you blankly and say, well, what's that? So we've moved on from that because people do now use the term. But as you say, it's used in a flippant way, as if it's a joke. And it's used to describe people that are clean and tidy or fussy. And I always say to people that, of course, OCD, like a lot of mental health issues, is actually on a continuum. And we all have some obsessions and some compulsions at some times in our lives. I mean, but mostly they pass. In OCD, they continue. If the activities you're doing and the obsessions and compulsions you have are helping you achieve your life aims, you've not got a problem. That's good. Yeah. You would want your airline pilot, when they fly you to Mallorca, to be fairly fussy and pedantic about the controls. That's all good. What OCD is when those take over and become the ends in themselves, so that you get people totally unable to move because they're controlled by the OCD thoughts, and they're far from succeeding. So, for example, some people have perfectionistic fears. They feel that everything they do needs to be perfect. And because perfection is not a human state, you end up with somebody who's sitting there in absolute squalor as a quivering wreck because it's all too overwhelming. And that's OCD. Whereas somebody that keeps the house a bit tidy, great. They can come round and help me with mine if they like.
Absolutely. And through your efforts to kind of re-educate, if that's the right word, people over the years, and obviously you are doing that with this book, but before that, how has the uptake been? Because I think sometimes, maybe someone's listened to this and they're at work and they hear their colleagues, and I've heard this before when I've been at work years ago, and I hear colleagues throw away the term OCD, and I'm thinking, oh God, come on. And they don't often want to confront them or say anything, or sometimes they do, but maybe it comes across too confrontational. How have you seen that over the years of?
I think it is difficult because, of course, the person that does it, and that goes into any form of bias, really.
Yeah, true.
I recently gave a lecture on unconscious and conscious bias, and we all hear things and you think, oh, do I say something? If I say something, am I going to be an aggressive bitch? And is it going to be counterproductive? So I think the way to deal with it is to take that person maybe aside and explain to them why that could be hurtful to somebody who had OCD. I think rather than calling people out, I mean, I don't know the answers to it, but that I think is in my experience the best way, because as soon as you stand up to too much to these kind of things, then you get labelled as, oh, she's a bit fussy, ignore her. Whereas if you take, one of the interesting things is everywhere I've gone to talk about OCD, to a lay audience, so not to a group of people that live with OCD, it's interesting that there's always a huge number of people that come up to me afterwards and confess that, either they have it or a family member. And I say confess because it feels like that. And, it's such a shame that there's so much stigma out there.
Yeah.
This is, I was saying to somebody, you didn't choose to have OCD, so why be embarrassed about it, really? It's something that's happened. It's not, you don't wake up and think, I'm going to have OCD today. It's one of those terrible things that strikes you down.
Yeah.
Just like I don't know, rheumatoid arthritis or type 1 diabetes, I don't know.
Yeah, valid point. Yeah, and of course, if we confront someone or call them out, we all have egos as humans, and sometimes we then put up our defenses, and then we don't listen. And whereas if, as you say, pull them aside, be gentle about it, they're more likely to listen. Okay, so you for the last sort of 35 years have run pretty much one of 3, is it? Inpatient OCD. I could use the word clinic, but it's not clinic, but hospital.
No, it actually, the one at Southwest London St George's is the only 24-hour fully staffed, dedicated inpatient unit.
Yeah.
And actually, we have a national network, unfortunately mostly based in the London area, of specialist OCD services for people that have gone through a series of treatments in their local area and have not succeeded. And we all offer slightly different areas. There's my good friend and colleague, Professor Naomi Feinberg in Hertfordshire, and she runs a very specialist OCD clinic, and she has outreach and home-based treatment being offered from Hertfordshire. Naomi is really, I would say, certainly among the, if not the top international researcher in the world on OCD, and does a lot of work. Her specialist is drug treatment and psychopharmacology, but she also uses psychological treatments as well. Then there's Maudsley, which is run by Professor Veal, and they offer an outpatient clinic and also a residential place, which is staffed 9 till 5. Then there's was our clinic, and we offered, as I said, the inpatient treatment. We also offered home base throughout the UK, and also some outpatient treatment. There's also, of course, the child and adolescent unit, also at SLAM, at South London and Maudsley, run by Bruce Clark. And there are also some beds in a private hospital, the Priory Hospital, and that's run by Dr Himanshu Taji. So we're all part of one unit, really, but we all do slightly different things.
Okay. Yeah, that was useful. Thank you. So the people Go for it.
But I should say as well that since I stopped in 2020, my successor is the lovely Dr Elenia Pampaloni.
Okay, cool. So that was really useful, actually, because for me to kind of map it out. You saw people over the years that, as you said, had kind of gone through many rounds of different therapies and treatments, and it not been effective for them for whatever reason. So what was different when they came to you? What hopefully made a difference? When I say you, your place.
Yeah, on my team.
Yeah, your team.
I think that's a really interesting one. And I think sometimes, and I'm very much like this in general, I think as therapists, we very often overcomplicate things.
Okay.
And I'm a great believer in paring things down to the simplest things. I think you need the minimum intervention compatible with health. Because if you overdo it, you can end up with a whole range of other problems as well. And so I think sometimes just somebody coming in, I think obviously there's going to be, they feel they're coming to a highly specialist unit, which gives an extra boost. Maybe that boosts motivation a bit. I'm not going to pretend that we were always wonderful local, I've seen many times wonderful local treatments and services, but being decried by people. And so, but I think actually to go back to the basics. So instead of doing, let's do a bit of this, a bit of that, a bit of the other, I think sometimes just take a breath, let's go back, let's start with straightforward treatments and let's see what happens. And if we get stuck there, let's analyse why we've got stuck there and see what else we need to bring in. I think there tends to be sometimes when people aren't familiar with OCD, they tend to get sidetracked and red herring. And very often people with OCD as well can't see, as we said, can't see the wood for the trees. So you get the therapist and the patient going off and trying everything, all and everything, and not just coming back, taking a deep breath, just sticking with one and giving it time. And I think that very often is very important. I also think in the inpatient unit, of course, as you said before, meeting other people with similar conditions can be very important. And a lot of our people that came in had spent many, many years holed up in the house, unable to go out or to socialise and to mix. And that in itself was a big wow, to do that was a big jump that took a lot of bravery. But then to realise that you're not alone, I think was very important as well. So I think that's it really, just being single-minded and sticking with the treatment, not going off on things unless you need to. I'm not saying you flog a dead horse, but you keep at something for a reasonable length of time. I often see, if you take medication, for example, I've seen, we know in OCD, if you're using SSRIs, that you need to be usually the top end of the dosing schedule, and that it can take 3 months for benefits to accrue. And then it can be up to 2 years that those benefits continue to accrue. Whereas I've seen so many people, they've had one drug for a month and they go and they say, it's not working. So the doctor switches them to another and then that's not working. And then they switch to something else. And you think, no, just take a breath. I know it's a horrible condition. I know you want rid of it as soon as possible, but just stick to the guns. And the same, of course, with psychological treatment. Don't go off and do all and everything. Just see what's actually needed and then apply additional things as and when required. The advantage to that as well is not just for the individual, but let's face it, we know that between 1% and 3% of the population, possibly more, have clinically relevant OCD. There's nowhere near enough treatments out there. And the simpler and effective we can keep the treatment, the more people we can treat. And wow, that's got to be a good thing.
100%. Yeah, I like that. Yeah, keep it simple, and time. I like that. And I guess one of the main treatments you're referring to is graded exposure or ERP. Yeah. So with that, then a question that comes to my mind is, how do you introduce that in a simple way? Like, because I'm guessing you're not trying to overwhelm people with the science and all of this. How are you explaining it in it? Yeah.
Well, I think most people that have had OCD for a while do recognise that there are two components to their OCD: the nasty, horrible, awful anxiety, distress-causing obsessions, and then something that they do to protect against that. So that can be a thought, of course, or a behaviour, the compulsion, that's designed to prevent the harm from the obsessive thought. But obviously, as we know, it's either not realistically connected or it's clearly excessive. And most people, you can then explain that, you have the obsessive thought, you do the compulsion. The compulsion does reduce your anxiety to begin with for a bit. Now, because high anxiety is horrible, something that reduces anxiety is a bit like a reward.
Mm.
And if you reward any behaviour, you increase the chances of it occurring again. Just like you give a dog a chocolate drop for sitting up and begging. Actually, we're exactly the same. All human beings are exactly the same. We like reward. The trouble with compulsions is they're not very efficient. So they only reduce the anxiety a little bit, and the effect tends to be short-lived. And before you know, the anxiety is up again. So you do another compulsion, another compulsion, another compulsion. So that over time, what you've got is somebody that's really, most of the time, highly anxious or distressed. Sometimes people don't say it's anxiety, they say it's distress or disgust.
Mm.
So most people experience that, and then you say, well, actually, if we can start to enter these situations that cause you anxiety, and to get you to stay there for long enough without doing the compulsions until the anxiety comes down, it will come down. So you want to pick something that causes some anxiety for them to start on, but anxiety they're prepared to tolerate. They're prepared to take that risk. And normally, once you go through it and you get a number of situations, and with the patient you grade them, they can identify some risks that they're prepared to take. Then you get them to try that out. And I always tell people to do things 3 times a day after meals, if possible. And they always say to me, why do you say after meals, doctor? And I say, I haven't got a clue, but that's what doctors are always supposed to say, isn't it?
Yeah.
But to be serious, I mean, something like that reminds you before, after meals or whatever, just so that you remember to do. And you'll find that as time goes on, although the anxiety goes up and it comes down, gradually over time, the anxiety that is caused by that, it's not, doesn't maybe disappear completely, but it gets much, much more tolerable.
Mm.
And once that happens, you can move on to another more difficult item. And I often say to people that it's not a race, because sometimes people will read about ERP and they think, oh, let's go to the very top of the hierarchy, and then everything comes crashing down.
Yeah.
And most people with OCD probably have had it for a little while, and yet of course, everybody would like to be over it in 2 weeks, and it isn't going to be like that. It's slow and steady wins the race. And as long as you're moving forward, I mean, yes, I've seen people that then spend so long on the first item that we never, they need a little push to move on up. But, in general, slow and steady runs the race. And you're not competing against anyone with this. You're there to get yourself better.
Yeah, I like that. Yeah, good point. Again, that time and patience comes to mind. When you talk about sticking with a treatment, and then here, slow and steady wins the race. Yeah, I like that. Thank you. Okay, so, and maybe we've answered this one already, but what is the thing you notice from your clients that recover much quicker than maybe some other people?
Oh, goodness. Why do some people get better quicker?
Yeah, maybe that's a better way of saying it.
It's very, very difficult to say. And there's been a lot of research, and I've done research looking at this. And in general, of course, people that have had the OCD for a shorter time tend to do better. And there may be several factors in that. That may also be related to the fact that OCD hasn't taken over your life. So other aspects of your life are still intact, still there. You may still have all the relationships and all the job opportunities that if you've had it for 20 years, it's not that they're not there, but they may be more difficult to re-engage with. So time is an important thing. I know from my colleagues working with childhood OCD, children do extremely well in general. Other than that, quite interestingly, I did some research on my inpatient unit. So that's people that are really, really bad. They have what can be classified as profound OCD. So this is a group of people where half of them were incontinent of urine and feces because they would get so stuck with their OCD. Something that's often not talked about with OCD, by the way. Quite a high percentage of them had abnormal blood lipids and physical things wrong with them, and were totally unable to function without 24-hour care. And amongst those, so they were quite a narrow group and they were all very severe, but I looked at predictors of outcome and I suddenly saw that people that were worse seemed to be improving more. So I thought, oh, that's a bit funny. And I thought, well, maybe it's just because they start off with higher scores on our measures. So I did a logarithmic scale. So what that means is that gets rid of that tendency. And it still was there. And so I can't really explain that, but I don't think that's an absolute, because of course, that if you've got mild problems, you maybe it's easier to get over. But in one group, I think what it was with these people that were really, really severely ill for so long had just reached the end of the tether and they were just going to go for it. They were really going to try. Yeah. They were going to give it their all, and it paid off. And the reason why I raise that is no matter how desperate things feel, how many, and these people had all had endless treatments, there is still hope. And that was shown by these people doing really, really well.
Brilliant. Yeah, thank you for sharing that. That's important. So a question I haven't asked on the podcast for a while is just advice or words on living with uncertainty.
Well, it's a difficult one, isn't it? Yeah. But we all live with uncertainty. I'm sitting here, we've had police cars screaming past. I don't know, a police car could come through my window at any point, chances are very small. I know that I've said to people, and being honest, if you don't do X, there is a small chance that Y may occur, but it's a very small chance. And they say, oh, but I don't want to take any risk. And I say, goodness, do you cross the road because you've got a chance of being hit by a bus or a car? And people say, well, isn't it dangerous? And I used to say, I cycle to work every day. And you say, I'm going to go home and do something really dangerous. I'm going to cycle in London. So there's uncertainty everywhere.
Yeah.
And none of us can be certain of anything. And it is tough if it's something that's really important to you, coming to grips with that, if it's maybe particularly about a child or a loved one, and that can be even more difficult. But at the end of the day, we all have to take calculated risks. And they're calculated risks. You're never going to put somebody at real risk. You want to take calculated risks. I will often demonstrate ERP. I'll touch the soles of my shoe, spread the contamination, and lick my hands. And people always say, "Oh, that's terrible. Hasn't that, that's awful." And I'll say, well, I've been doing that for 40 years. I'm pretty tough. I'm pretty strong. Maybe I have had 1 or 2 more bouts of D&V, diarrhea and vomiting. I don't know. There's no way to know. I may have got it anyhow. But certainly it hasn't damaged my life and what I set out to do in life, whereas OCD can.
Yeah.
So I think, it's weighing up the risks and saying, actually, the risk and living with the uncertainty, isn't that better than the destructive force of OCD?
Yeah. Really spot on. Absolutely. Yeah. Yeah. When you weigh it up like that, you're like, it's a no-brainer. So, words of hope for people listening who have OCD. What would you tell them?
OCD is horrible. We know that. But hey, you can get better. Even if one bout of therapy doesn't work, please don't give up. Don't go to ground and say, well, I'm untreatable. This is not true. There is light at the end of the tunnel, this one way or the other, for almost everybody. Or shall I say everybody? Because I'm just covering my back by saying almost.
Yeah, of course. Well, we also need to keep in the uncertainty, right?
That's right.
Yeah. Okay, so a couple slightly different questions now. If you could pick up the phone and call the 20-year-old version of Lynne, what would you tell her?
I would say stick with psychiatry. You'll find it really, really rewarding. And hopefully you may be able to change some people's lives.
Nice. Awesome. And you've got a billboard in London. You can have anything written on that billboard. What does it say?
I'm sorry, I'm going to be difficult here, Stuart, and I'm going to say 3 things. And one is OCD is not a joke. OCD can be a serious, even life-threatening condition, but there's light at the end of the tunnel and treatments work.
Nice. We have there's that long billboard outside Clapham, I think. It's several
you'll have
billboards.
To do it so you come in.
We'll spread it. Yeah, exactly. And then, lastly, anything else you wish you could have said today?
I don't think so. I think we've covered everything, and I just say thank you very much for inviting me. And for anyone that's listening, please, please, please do keep going. I know you've got to be very, very brave, and it takes a lot of guts to face up to OCD, no matter how you're treated. If you're treated by exposure or even just taking the medicine, you need to be brave. But please do it, because it is worth it. And I could tell you of hundreds of people that have taken that step before and are now living fulfilled lives. So please don't give up hope.
Yeah, brilliant way to end. Thank you so much for sharing all your wisdom with us. I really appreciate it.
Thank you.
Thank you for listening to this week's podcast. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/theOCD stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.